very elegant speakers. هيبقى أول ستوك عن أسمى مانجمنت the past present and future من الأستاذ الدكتور سمير خضر، وبعدين في أسمى مانجمنت practical approaches الأستاذ الدكتور عادل خطاب، وأسمى مانجمنت flexibility is a must الفند ستادي بالأستاذ الدكتور حاتم الملواني. وأرجو إن احنا نخلص on time عشان نلحق نتعشى بس.
إن شاء الله. بسم الله الرحمن الرحيم. كل الشكر والإعزاز والتقدير لأسرة البرونكولوجي، الأخ العزيز طارق صفوت والأخ العزيز طارق محفوظ ومجلس الإدارة كله على التجمع الجميل السنوي اللي بنشوفه مع بعض. My concern today with the history of asthma from the start, and as we know, asthma was titled as a disease of the muscle. That's why bronchodilators were taking the main brunt in the management of asthma, especially the short-acting one. And after that, the definition of that asthma is a chronic inflammatory disease, and the inflammation is the main part or the cornerstone in the pathophysiology of asthma. That's why inhaled steroid introduced in 72 with more and more use of short-acting beta-2 agonist till the era of the long-acting beta-2 agonist, which started in 90 and defined asthma as a bronchospasm and inflammation, with the option that the early intervention with long-acting beta-2 agonist and inhaled steroid will be a safeguard against the occurrence of remodeling. So asthma is a dynamic disease, fluctuating by time. It is not a stable disease, and inhaled steroid constituted the cornerstones in management of asthma. The occurrence of exacerbation is going on when controller therapy is reduced, but when we initiate controller therapy, the occurrence of exacerbation is decreased. That's why most of our patients are using short-acting beta-2 agonist to cover the symptoms, with the ongoing chronic inflammation going on and on. So the use of short-acting beta-2 agonist is overused, and the use of the anti-inflammatory inhaled steroid is underused. In Sweden, and this slide is memorial because it is since about 4 years, inhaled steroid are used only by 55% of the patient, and 45 are stopping the inhaled corticosteroid when symptoms are ameliorated. So if we apply the guidelines in the management of asthma, we can't attain till now optimal control. So under treatment is the picture or the profile of management of asthma. You are familiar that asthma is increasing, though that drugs within our hands, and we supposed in 2020 there will be 300 million asthmatic patients. Exacerbations constituted the main brunt of management of asthma, and the direct and indirect dose are increasing. In defining exacerbation, we have to be familiar with the type of exacerbation. We have allergic exacerbation and non-allergic, and this means a good difference, because in the allergic exposure, it is mainly an eosinophilic inflammation, And in viral, it is mainly neutrophilic, and not all the story looks like. So, neutrophilic inflammation is partially covered by corticosteroid, and eosinophilic inflammation are totally covered by inhaled steroid. That's why what is recent in classifying asthma, we are not now classifying asthma as mild persistent and moderate persistent and severe. The new classification is going on to the target response. Totally controlled asthma, partially controlled asthma, and uncontrolled asthma. This is what's new in the classification of asthma, taking in consideration the response to treatment rather than the severity, because the severity is variable on time. As regards the occurrence of exacerbation, we have to be familiar with the direct and indirect markers of exacerbation: high sputum eosinophils, indirect hyperresponsiveness, and exhaled nitric oxide. This is a virus which are very common in the occurrence of exacerbation. Going to the immunopathology of exacerbation, the allergic and non-allergic, in the virus, there is stimulation of the epithelium with the release of IL-8 with neutrophilic aggravation and activation, and the main mediators is myeloperoxidase, which is not totally covered by inhaled steroid. Going to the right side, when the allergen is stimulating the mast cell with the release of mediators, both in the early and the late phase, with induction of eotaxin and eosinophilic infiltration, active and inactive form. The right side of this slide is totally controlled by inhaled steroid. The left side is partially controlled. That is the notion that asthma is not one disease. It is a heterogeneous group. Not all asthmatic patients are the same. Exacerbations are not the same also. So we have one group whom are totally affected by inhaled steroid, and another group whom are partially covered and the difficult to treat, which is not controlled by inhaled steroid. In exacerbation, in some cases, there is a release of what is called, in exacerbation, there is a lack on the macrophage of what is called histone deacetylase. We have 11 types of histone deacetylase. The most important is the number 2. This is used by corticosteroid to switch inflammation. If it is lacking, corticosteroid will not cover the exacerbation. Also, with allergen challenge, there is in some exacerbation the release of matrix metalloproteinase, which is unaffected by corticosteroid. What is recent is to antagonize this enzyme by what is called the peroxisome proliferation activated receptor gamma, and this is still under research. So asthma exacerbation are affecting the direct and the indirect cause of management of the disease. There are still 7% of patients needs to be hospitalized, 10% needed emergency treatment, 25% had to see their family doctor, 17% are missing at work. In Alexandria, we are conducted work concerning the role of asthma in absenteeism. In the school age, it is responsible for 25% of the total absenteeism. In some factories, it is responsible for 21% of the total absenteeism. If corticosteroid is the golden drug which affect asthmatic inflammation in most of the cases, we have to be familiar with the mode of action. Corticosteroids are acting by two arms. The first, the non-genomic effect, that it inhibits the transcription factor or the markers of inflammation. The most important of them are nuclear factor Kb, CREB, and activator protein 1. This will decrease the inflammatory protein and the influx of cytokines, enzymes, adhesion molecule. On the other hand, the non-genomic the genomic effect through DNA binding, this will cause increased anti-inflammatory cytokines and protein. IL-8 is a good cytokines for prevention of asthma, and IL-1 receptor antagonist. But this effect, which is a genomic effect, is accompanied by side effect. That's why the new corticosteroid, which will be within our hands, will abolish the genomic effect and going on to the non-genomic effect. How we can control asthma exacerbation? We have, before diagnosing that this patient in exacerbation, please look to his ENT part. Chronic sinusitis, allergic rhinitis, and going down to the gastroesophageal reflux. Pharmacological treatment is one aspect in the management of asthma. That's why environmental control is the best. And in difficult to treat asthma, the more insult which occur by persistent environmental inflammation is the cause of resistance to corticosteroid. And we have to educate our patient and make a proper follow-up for them. What is the principle of pharmacotherapy in moderate up to severe asthma? Is using both long-acting beta-2 agonists in addition to corticosteroid. This is more powerful to antagonize exacerbation than doubling the dose of the corticosteroid. Why? As we know, corticosteroid will inhibit all the steps of allergic cascade, from cytokine production, adhesion upregulation on the inflammatory cells, inhibit ICAM1, VM1 on the activated epithelium, endothelium, and fibroblast. So all the steps are covered by corticosteroid. What is the importance of long-acting beta-2 agonist? The principal cell, inflammatory cell in asthma is eosinophil. So corticosteroid will prevent the infiltration, and long-acting beta-2 agonist will prevent the activation through a different mechanism. And also, LABA has a direct cytoprotective effect in asthma. Corticosteroid has indirect effect. The phenomena of crop formation is abolished by using long-acting beta-2 agonist and inhaled corticosteroid. Now, looking to the immunopathology after our patient are using inhaled steroid, what are the most important inflammatory markers? Nuclear factor Kp, granulocyte maturation colony factor, and tumor necrosis factor alpha is decreased in the submucosa. Significant decrease in the eosinophil, and the adhesion molecule will be reduced in both the endothelium and epithelium, with the end result of adding more long-acting beta-2 agonists. These markers will reduce by mechanism quite different from the using of inhaled corticosteroid. This slide is well known for you, and we know the synergistic effect between long-acting beta-2 agonist formoterol and budesonide. The phenomena of reversible esterification of budesonide, when we are use the budesonide and it is translocated and it is binded and they make the therapeutic effect, part of this budesonide will be esterified and it is converted to budesonide ester, which is inactive. When we are in need of corticosteroid effect, these esters under the effect of lipolysis will be changed to active budesonide. So, formoterol in the management of asthma allows adjustable dose with rapid onset of action and sustained duration of action. So it has some anti-inflammatory effect which is not seen except in the presence of corticosteroid. We are not using long-acting beta-2 agonist to control asthma. We are using it in addition to corticosteroid, which are till now the cornerstone in the management of asthma. In some
2 minutes remaining.
ده تبعنا ولا ناقص دقيقتين؟ ناقص دقيقة واحدة. So Formoterol could affect the early and the late phase, but with no effect on the inflammatory cell. So the optimal anti-asthma therapy, bronchodilation, bronchoprotection, anti-inflammatory effect, improved asthma control, and good compliance. What is new? عشان الصعايدة ما يزعلوش. What is new is the development of long-acting beta-2 agonist, which is using once per time in Decatrol, or using corticosteroid with long duration of action as mometazone, or using corticosteroid which is cleaved by enzyme only in the lung, or uses of antagonist of IL-5, tumor necrosis factor, or anti-IgE. And lastly, thank you very much.
Thank you, Professor Samir, for this beneficial and illustrative talk. And I ask Professor Adil Khattab to speak about asthma management practical approach. Bismillahirrahmanirrahim. Thank you, Mr. Chairman. Practical approach in management of asthma. Although we all know the definition of asthma, I'm not going to repeat every word. Every word is important, but I'm going to concentrate in 2 words only. That asthma is a chronic inflammatory disease and it's a variable disease. Although we know by heart the definition and there is many drugs, the prevalence is increasing, 300 million people, and it is anticipated in the next 20 years another 100 million will be added. One of the major problems in management of asthma is that the underestimation of the patient. Patient usually underestimate their control of asthma. They are perceiving their asthma to be better controlled. When we look here to the uncontrolled asthmatic, more than half, 57%, think that the asthma is relatively good. This leads to a very important, crucial study, the INSPIRE study, and the results of that study issued this year, International Asthma Patient Insight Research. Although patients on that study were all in corticosteroids, and some of them on both corticosteroid and long-acting beta agonist, still 3/4 of them depending on the reliever, the rescue therapy. More than 40% used the reliever more than 3 puffs per day. That's why only 30% of the asthmatic in this study are well controlled, and the remaining either poorly controlled or not well controlled. In spite of that, severe asthma or very severe or asthma exacerbation, the symptoms are the same as the symptoms of asthma. And patient can realize or identify the worsening and increasing the intensity of their symptoms. Also, are confident that they can self-manage because they can recognize there is worsening of their symptoms, they can intervene early. 90% said that they want immediate relief, and more than 80% are confident to intervene early. Variable, from the definition, asthma is a variable disease. And due to many allergen and many trigger factors, there is increase in the course of asthma, intensity of symptoms, and under control of asthma. It's not a stable disease. This is very important in the issue of management. But we are usually depend on fixed dose policing in treating variable disease. And here, when we have exacerbation with fixed dose, the situation is the patient and the disease is under control, under treated. This leads to severe exacerbation, to bursts of oral steroids, hospitalization, ER management. And sometimes when the disease, there is remission, we are over-treating the disease, giving much medicine, much drugs, and much cost. The early signs of worsening starting and reach its peak within 6 days. But here, early in the early phase, this is the window of opportunity, the patient can intervene by increasing the doses, so he will not reach to the worst stage. Here is paradox in treatment of exacerbation. Usually, patients and physician depend on short-acting beta and rapidly acting the reliever, while exacerbation and severe asthma means increase in inflammation. But usually, the patient depends on increasing the rapidly acting bronchodilator instead of increasing the anti-inflammatory. This is what's called the treatment paradox. Whenever we have exacerbation, we have increased both the reliever, of course, patient gets better to relieve the symptoms, but we have to increase also the anti-inflammatory. Early adjustment of control therapy, the anti-inflammatory with the reliever, will decrease hospitalization by 43%, the emergency visits will decrease by about 30%, and days of work decrease by more than 40%. How we can achieve this? We can achieve this simply by leaving the old belief, the old policy of fixed dose control of variable disease. And when we have the early intervention, beginning of worsening of symptoms, we have to increase both the reliever and the anti-inflammatory, so that the patient will not reach to the maximum worst symptoms, exacerbation, and will need of oral steroid, increased sources of ER visits, and hospitalization. Can Symbicort do that? Yes. Because the components of the drug, the formoterol, long-acting beta-2 agonist, beside the long duration, the main characteristics is the rapid onset of action within few minutes, and it is full receptor agonist. And there is dose response within labeled dose. And comparison of Symbicort 160-4-5, either 2 inhalation or 1 inhalation, compared with salmeterol, fluticasone 250-50, there is increase in FEV1 with highly significant difference in the early part, in the first few minutes, and this increase will be up to 30 minutes. There is increase, either single inhalation or double inhalation. And of course, this will give the patients immediate effect of dyspnea score compared with the other combination. What about the safety? If this combination and the adjusting the dose will improve the patient, what about the safety? Comparing 10 times the needed dose of formoterol, 20 mic, with terbutaline 10 mic, the main side effects are the tachyarrhythmia, which is due to the hypokalemia. If we compare 10 times the dose of formoterol with terbutaline, the hypokalemia is much more with the terbutaline compared with the 10 times the dose of formoterol. The same with tachyarrhythmia. Tachyarrhythmia much more with terbutaline compared with formoterol. Regarding budesonide, as mentioned by Professor Khedr, budesonide was the first steroid approved by FDA for single dose therapy. It's effective for 24 hours. This is because of the reversible lipolysis and esterification. And as shown here, the anti-inflammatory effect proven by the level of tumor necrosis factor alpha after 12 hours, it remained significantly with budesonide when compared with both fluticasone or placebo. The synergies, all of you know about the synergies, the effect of the long-acting beta-2 agonist formoterol beside its bronchodilation effect on the glucocorticoid receptor, and vice versa, the action of the budesonide on the beta adrenergic receptor. Beside the anti-inflammatory effect of budesonide through messenger RNA, this will upregulate the beta-2 receptors. Upregulation is very important because you know the inherited tachyphylaxis or tolerance characteristic of beta agonists, mainly with the short-acting, will be abolished with the use of combination of the long-acting with the steroids. Also, formoterol acting as a bronchodilator by only the alpha part of its molecule, while the beta and the gamma will act through the monoamine phosphokinase to form what's called translocation of the glucocorticoid receptor, another activation of the glucocorticoid receptor. And here, if you see the synergistic activation and translocation of the glucocorticoid receptor, here in A, this is the shape of the inactivated glucocorticoid receptor in cytosol of the bronchial smooth muscle. While here, this is the picture of the activated glucocorticoid, the translocated 1 hour after activation by combination of formoterol. So, the adjustable maintenance dose, why it succeeded? Because it gives overall disease management than the fixed dose, than higher average maintenance dose given constantly. Because it will allow the patient early intervention at the time of window of opportunity than conventional fixed dose. The adjustable maintenance dose has both anti-inflammatory, which is very important in cases of exacerbation, beside the bronchodilator effect treatment used during worsening rather than relying on the reliever only. Also, it's effective controlling and it maintains at a lower daily dose instead of giving a higher unneeded dose costs and side effects when the disease is controlled. So adjustable dosing controls a variable disease, which is the definition of bronchial asthma. Thank you so much for your kind attention.
كده تمام. ثانك يو بروفيسور عادل خطاب. هو الحقيقه الدكتور عادل يعني التزم بالميعاد قوي، فيعني يا ريت الدكتور حاتم الملواني يلتزم برضه عشان نلحق نتعشى يعني. البروفيسور حاتم الملواني will speak about asthma management. Flexibility is a must.
No, it is not a must. Is it a must? It's a question, okay? Mr. Chairman, colleagues, ladies and gentlemen, as an extension of Dr. Khattab's lecture, I'm going to present a study. This study is highlighting a concept in the use of ICS and LABA. And this actually represents a deviation from the classical guidelines we know. The guidelines say that you give the LABA and ICS from moderate and severe asthma, and then you maintain the same level of therapy for about 3 months. If the patient is a good responder, only at that time you are going to consider stepping down. But this concept, as Dr. Adil mentioned, is AMD or adjustable maintenance dose, and it is comparing this with a fixed combination. The study is under the title of SUND study or Symbicort, as a combination of benzoate and formoterol up and down. Actually, you are going up and down with your medication according to level of severity of symptoms. But how is this level of symptoms judged? This, and for the first time, I think, the patient himself had a share in the decision making. The patient is going to evaluate his symptoms. Once he finds himself improved, he is going to reduce his medications. But of course, this is not absolute. It's under surveillance and the guidance of his physician. This study has been performed in Europe, and I think it utilized more than 90 centers. In the run-in period, patients were allowed to be put on ICS only. They didn't receive any longer-acting beta agonist. After this run-in period, 2 weeks, patients who proved not to be responders were included in the study. They received two fixed combinations, salmeterol fluticasone on one hand, and formoterol benzoate on the other hand. In this period, after the end of this period, patients who proved to be responders were classified into two groups. One group, they were put on the same fixed dose of salmeterol and fluticasone. But people who were put on formoterol and benzoate, they were tested in another different way. They have been informed that if during the last week of this first month they were doing well, then they were allowed to refer to adjustable maintenance dose. What does this mean? These patients, to start with, they receive 2 inhalations twice a day of Symbicort or benzoate formoterol. This is the traditional dose. If they improve, and improvement was judged by the need for reliever use on one occasion on 2 days or less, and no nighttime awakenings due to asthma during the last week of the first month of the study. At that time, they have been informed to reduce their medication to half, 1 inhalation twice a day. But on the other hand, after shifting or after halving the dose, if they experience worsening of these symptoms, again, note at this point, the patient is a judge. He is evaluating and assessing his condition. If he feels that he is deteriorating, the deterioration is assessed by increase in the reliever medication, and again, he is awakened by asthmatic symptoms at night. Now he is allowed to use the same drug 4 puffs twice a day. But if you think over, في هنا الحقيقة نقطة. formoterol 4 puffs twice a day في ال preparation ده يعني 18 microgram. 18 microgram twice a day, this is not a toxic dose. This is different from salmeterol. Salmeterol, the dose 50 microgram twice a day. You cannot increase it. If you increase it, the dose response curve will not allow this. But formoterol is very flexible. You can use even doses of 24 microgram twice a day without any significant toxicity. This is a feature of formoterol. So don't wonder about the increase in the dose of formoterol together with benzoate. Again, he improved after 7 or 10 days. Stepping down in the same way will be performed. As you see, this is very flexible use of the medications, including formoterol and benzoate. هنا في الستادي they relied on a very important point. هم في الجادجمنت هنا قالوا well controlled asthma weak. ما قالش total control لأن مش صعب يدور على total control. The definition of well controlled asthma weak, this patient has no nighttime awakening due to asthma, no exacerbations, no change in asthma therapy, and the maximum use of relievers of 4 occasions per day وما جالوش أي exacerbations, and this is the definition of exacerbations كلنا عارفينها كويس. What about the results? زي ما هنشوف هنا the use of formoterol and benzoate في الستيب الأولانية اللي هو كان fixed dose. He's comparing the two combinations. It's evident that formoterol and benzoate has superior effect on the FEV1 improvement and in FEV1 compared to salmeterol fluticasone. If you come to fixed dosing again, الحقيقة this is يعني a very neutral non-biased study. تقريبا كان الإفكت بتاع formoterol benzoate is not much different from salmeterol and fluticasone. But in the 6 months open period اللي هي الفترة اللي ابتدى يبقى فيها adjustable maintenance dosing, ابتدوا يحسبوا number of weeks which are well controlled. لأن ما أقدرش أعتمد على شهر أو حاجة. بعد ال7 شهور دول أقدر أعرف number of weeks اللي هو العين is well controlled. هنبص نلاقي ان fluticasone benzoate as compared to salmeterol fluticasone, fixed dose can formoterol benzoate is superior, but again with the use of adjustable maintenance dose, stepping up, stepping down, patient monitored, patient adjusted is superior, and the number of well-controlled asthma weeks is better. If you come to the dose used, لما هنا كان من ضمن الكونسبتس هنا، هل انا لما استعمل adjustable maintenance dose توتالي هقدر اقلل اللود of the drugs سواء البيتا agonist او البيتسونايد on the patient؟ فهنا the same load has been achieved by formoterol bisoprolol as compared to salmeterol fluticasone, but with the adjustable maintenance dose it seems that the total drug load was less. Severe exacerbations في أي study الحقيقة بيبقى very important parameter for assessment of efficacy of the drug. هنا هنلاقي مفيش فرق كبير ما بين two fixed combinations, formoterol bisoprolol and salmeterol fluticasone, but with adjustable maintenance dose, the number of exacerbations has been reduced by almost 40%. Where patients with adjustable maintenance dose, they needed less risk medications with, as compared to the other two fixed combinations. Daytime symptoms with the adjustable maintenance dose were very much less, and nighttime awakening as well was very much less. So we have to make some conclusion. The fixed dose using bisoprolol formoterol or salmeterol fluticasone provides similar levels of guideline-defined asthma control. But when you come to the use of adjustable maintenance dose, better asthma control with very marked reduction in the load of drugs. And actually my last message is that you have LABA, you have the ICS. Guidelines focus on this. You have to use both LABA and ICS. In what way? This is dependent on your experience, and don't forget the individual response between patients. You cannot promise that if I put you on this adjustable maintenance dose or fixed dose or whatever, you will do well or not. It's a matter of experience, but stick to guidelines. It's essential to use ICS in all steps of asthma, ICS and LABA in moderate and severe asthma. And thank you for your patience. Thank you very much.
Thank you, Professor Hatem, for your very interesting talk. وفاضل لك كام دقيقة؟ فاضل لك 5 دقايق ممكن تعمل فيهم أي حاجة يا حاتم. ممكن تلعب أي حاجة فيهم. by the end of this session يعني أنا شايف إن الناس كلها أغمى عليها. دكتور طارق محفوظ، العشاء فين يا دكتور طارق؟
هو العشاء ان شاء الله هيبقى في حوالين البسين، حوالين حمام السباحه في الميريديان هنا، بس هما اداره الاوتيل بتستاذنكم لان احنا السبب هنتاخر نص ساعه في العشاء عشان هما بيعملوا سيت اب، فنص ساعه يعني بعد نص ساعه نقدر ندخل العشاء. مظبوط، نص كده، نص بالكتير يعني ان شاء الله.
طب ما اطلع حاتم، اطلع حاتم كمل.
اطلع كمل.